in allergy clinic, we see eczema, we see asthma, we see food allergies, and we see environmental allergies. And in the past, I feel like each of those disease processes were actually each of those disease processes were almost thought of as individual entities, and now what we're seeing is that it's all like someone's atopic and they have one disease, they're just more prone to have the other. And because of that realization, we're actually using some of the medications that's approved for one indication and trying it out on another indication. You know, that is a really good point. And this is a discussion actually that I had with Dr. Kassal recently. The problem is, you know, how do you decide who gets the biologic and who doesn't, right? Biologics are really, really expensive. And if you then start say everyone with food allergies can have biologics, that really limits, you know, it's cost prohibitive, and how much do you know, it becomes very expensive. So then these are kind of things that I think the medical community has to kind of decide upon, is when do you offer biologics? Do they have to go through certain steps before we offer it, or do you just offer it at the get-go? For some of these biologics in the food allergy space, because it's still new, we are, you know, our inclusion criteria is really to make sure that the person actually has the disease we're checking them for, but not so severe that the study might actually be a safety issue. So it really is not basing it on severity at the moment. But I think the worry is, because I'll use omalizumab as an example, because there are lots of trials out there. We found decreased adverse events on Xolair. We see that the time to maintenance for reaching, you know, the maintenance dose for foods is quicker with Xolair. So then it becomes really difficult to decide which patient to use it for and which not. So severity would be a great way to make it, you know. Yeah, so I mean, in terms of omalizumab, it is currently approved for asthma, and that's the data we have. It's approved for chronic urticaria. That's the data we have. We have a basic understanding of how it works in food allergy, but we don't understand everything. It has been it's quite safe. We haven't seen too many kind of adverse events with Xolair specifically. It's been out there the longest. So a lot of those concerns have actually been answered and looked at, and we have data from the asthma trials going way back. But some of the newer drugs like dupilumab, we just don't have the data. We don't know how long-term effects. We don't know we know that it's an, you know, IL-4, IL-13 blocker, but how that affects more downstream cytokines down the line, we don't know.